I'm very pleased to introduce the next speaker, actually a man after my own heart, as he asked for a concise introduction. So I'm very pleased to introduce Professor Rohit Shankar, who's a professor of neuropsychiatry at Plymouth Medical School.
Thank you. So in addition to my Indo-Cornish accent, which I bring here, I seem to have got a frog in my throat, which is adding a bit more Donald Duck to it. So you might have to bear with that. So and the occasional cough. So obviously being a professor means you're a professional beggar. So you go around gathering money everywhere you can. So clearly I've done a pretty good job going with a begging bowl in a Rolls Royce. But today quite a bit of my talk is quite narcissistic, where I've been highlighting a few of my own things. So obviously the disclosures matter. I'm going to be a mood hoover here and bring down the tone of the conversation a bit down here. All these people who are coming behind you, the one thing common among them is they are not alive today. They've all died of what's called sudden unexpected death in epilepsy. Sudden unexpected death in epilepsy is a big killer. I'm biased. I research into that area. But I'll put the statistics together for you. So I need to thank SUDEP Action, which is a national charity, for getting the permissions to put these photos here. But I think there is something. If you see the faces, it's an age range, no barriers of sex, ethnicity, across the board. So SUDEP is pretty much a EDI killer in a way. And what you do have is 21 people every week. 3 today are going to die because of epilepsy. In the coroner's report, section 1, it's going to be epilepsy or SUDEP. That's going to happen today in England, in UK. So today my talk's going to be very much going through what is SUDEP, talking you through the SUDEP pathophysiology, the epidemiology, the modifiable and non-modifiable risk factors, talking about where the social issues come in and how comorbidities impact, and looking at interventions and where we are headed into the future of this. All the publications that I show, especially mine, are all free to access. It should help you treat your insomnia. So each paper is guaranteed to give you 3 nights of good rest reading this thing. So SUDEP in epilepsy literature has been largely neglected. It only came into vogue thanks to some brilliant piece of work done by Lena Neshaff in King's in the 1990s, where she saw that a group of children and young adults with intellectual disability were dying when they had epilepsy for a long periods of time. So that case series, which emerged in early 90s, set the ball rolling. And over time, depending on where you are, it has emerged as one of the most important epilepsy-related death conditions. And I'll explain the large gap in range between 17% and 50%. It's actually very interesting to unpack that. The SUDEP is basically the leading cause of death in people with uncontrolled epilepsy. And I'm going to again unpack these words. What does uncontrolled epilepsy mean? And where does that sit generally? But what we do have is major research emerging. And in 2018, the Americans came to the party. It was the Dunkirk moment, where you had them saying, we're going to get rid of SUDEP. And Cure piled in $300 million wanting to get rid of SUDEP. So we are on the bystands, obviously, being the supporting act. So hopefully we'll get there. So relative to this thing, let me put it into context. Everyone here, the man on the street, is familiar with asthma. On an average, there are around 5.5 million people with asthma, of whom sadly, around 1,300 each year died due to primarily because of asthma. Epilepsy, we got 600,000 people with epilepsy in the UK, and almost the same numbers die because of epilepsy. It's a 8 to 10 time bigger killer That's what it is with epilepsy. And coming to unpack, where does SUDEP sit? SUDEP is one of the biggest causes of deaths in epilepsy, along with status. But one of the biggest challenges which we have is that SUDEP is a coronial diagnosis. It's not a medical diagnosis. So the coroner has to diagnose SUDEP. Now, coroners come in all shapes and forms and wisdom. So they can be, you're going to be very lucky to have a coroner who's also a neurologist and an epileptologist. Can't think of any in the country. Also, the coroner, which is really interesting, you have more SUDEPs in April than in March. And the reason for that is that the coroner, though independent, the budget is controlled by the council. The council renews the budget annually, every year, in April. To diagnose definite SUDEP, as I will show you, you need a neuropathological autopsy and a toxicology, which costs around 750 pounds extra. So the coroners are more likely to ask for an autopsy, neuropathological autopsy and toxicology in April than in March. So anyone very morbidly wanting to die of SUDEP, prefer that in April than in March, that you get a diagnosis. Otherwise, you end up with epilepsy death as your diagnosis. And we have to do a lot of work to unpack whether it was a SUDEP or not. I'm sorry about the gallows humor here, but I think that's a way to convey some of the key thoughts in this. So if you think about SUDEP risk actually is in the top 10 in developed countries of all causes before the age of 70. Then it's the 5th highest cause of life years lost in men and 8th in women. The second most important and sort of the most, after stroke, the cause for death, which accounts for in neurological conditions. And the risk for SUDEP, especially in children, in young adults, and this is where the social issue comes in, when they go off to universities, when their lifestyle changes, habits change, alcohol, possibly drugs, nocturnal awakening and things like that. And when that cocoon breaks, they are at higher risk. We see quite a few deaths emerge at that level. And the cumulative, this was a wonderful study done in Iceland, where they did a 40-year follow-up of a cohort, shows the value of cohort studies, from a whole cohort, 40 years, and found the rates of deaths of SUDEP in that cohort to be 7 to 8% people with epilepsy. So definition-wise, SUDEP. So we're going to go into this sort of Alice in Wonderland world of SUDEP diagnosis. So for SUDEP, what you do need is basically it might be witnessed, it might not be witnessed. You have to rule out quite a few things like drowning, etc. And funnily enough, you can diagnose a SUDEP with or without the evidence of a seizure. The reason for this is that you have to have a history of seizures, and even it might be a 30-second seizure, a 5-second seizure. And if that, so seizure itself is not there as a diagnostic thing. We have to exclude status, which has a whole different 30 minutes there and everything. That's a separate talk. And this is again where it comes back to the March-April divide. Because for a definite SUDEP, you need to have post-mortem examination which does not reveal any obvious other overlying causes or conditions to influence it. The classification of SUDEP has evolved and made it more granular. So definite SUDEP is when it meets all the above criteria. So with or without seizure, rule out drowning, rule out status, get the neuropathological autopsy done, have a history of epilepsy, you can diagnose SUDEP. This is where most people do end up, is probable SUDEP, where in the lack of post-mortem examination, all the other criteria is met. So that is usually probable SUDEP. Possible SUDEP is another one where you can't rule out SUDEP, but there are other factors. Say the person had, say, cardiac problems or asthma. So there might be something which is running in competition for the cause of death. So that's where possible this thing, but it all boils down to lack of postmortem, and that's where it sits. Then there is SUDEP plus, where you think that it is SUDEP, but there are other factors also, and I'll explain why, because it can't be seen in isolation about other factors, things like cardiac problems or heart problems, etc., which might also be adding on and mixing up with it. And more recently, in 2013 on, there's a new concept called near SUDEP. So this is where there is asystole due to seizure, but you can revive people from it. And there have been cases of that which have emerged. So how does SUDEP happen? Now, one of the best studies in this, and I really put my hat out for that in one way, Philip Rylin put together something called the Mortimer study. He never got a single penny of funding for it. It has been cited over 1,000 times. It's one of the best studies which has been done because he managed to pick up cases where SUDEP happened live. What he did was he contacted across all the major countries, Australia, New Zealand, US, Europe, UK, all the epilepsy monitoring units, and asked them for all the cases who died while in epilepsy monitoring in cardiopulmonary crisis. So out of 160, 147 units replied back. He picked out 16 SUDEPs, including 10 which had full metrics of all the cardiopulmonary issues. Almost SUDEP happening, so gory, but it's almost happening live. And because of that, we know the pathophysiology of how SUDEP might be happening. So what we do understand is there might be a predisposition to SUDEP, which could be the etiology, incidental, social issues could be there. We of course know that there might be a long-standing seizure issue, which is there, acting on it. Factors which relate to treatment, like compliance, then withdrawal, abrupt withdrawal of medication, alcohol, though not yet nailed down, it sort of smells really strongly in that. And then you have the precipitating seizure, which happens. You don't need to see it, but it has to happen. And then that leads to apnea, hypoxia, cardiac arrhythmia with cerebral shutdown. And there might be a reason why it becomes fatal, and that could be the cardiac vulnerability or something else which is there. And that tends to, and especially nocturnal monitoring. Now, out of the 10 deaths, out of the 16, 10 it happened at night. So there's something about nocturnal, and I'll come to the evidence on that. And that leads to SUDEP. So this is the thing. So there is a lead up to it. Even though the event is sudden, it's almost like tsunami. You don't understand how it happens, lull before the storm, how big is it going to be, but the destruction can be quite significant based on other multiple factors. And the other thing which is really interesting is that SUDEP varies with epilepsy population. Not everyone with SUDEP is homogeneous. And this is where inconsistencies come in about how we talk to our patients with epilepsy on this. So again here, if you take a look at this, what you have is one person out of 1,000 people with epilepsy today are not going to be alive next year this time if they are in primary care. If they are in epilepsy clinics with epilepsy nurses, secondary care, 2 out of 1,000 are not going to be alive next year this time. But what's really galling is the special populations, people with intellectual disability. 25% of people with intellectual disability have epilepsy. 70% are treatment resistant. 2% of the population has intellectual disability. 12 comorbid conditions usually for them. And in that population, and then those who are refractory, and those who go towards surgery, your rates scale up to 3 to 6 per 1,000 each year are going to die because of SUDEP. And this is what we looked at. We looked at, I'm very interested in intellectual disability, and we looked at conservatively 3 times higher risks, which we found in this population. So if you think about risk factors, you can start breaking them down. there are some direct research risk factors. Number one, of course, being the seizure. A generalized tonic-clonic seizure, if you have greater than 2 a year, your risk of SUDEP goes up by 5. Greater than 3, it's 15 times. So it goes up significantly. So anyone who's here who sees seizures regularly knows these are very small numbers in one way. But so generalized tonic-clonic seizures, very important to gain a grip of. Nocturnal seizures. 70% of all SUDEPs happen at night and there is a question mark about surveillance, about nocturnal this thing. My own dodgy research, which got picked up by NICE, basically highlights that the safest way to mitigate SUDEP is to put in a baby monitor, an audio monitor. You can reduce harm by 60%. So technically 42% of people, 60% of 70, basically 42% might still live if you put a baby monitor in. So an audio monitor. No smartwatches don't work. They don't work as well. And there are a lot of beautiful stories around that. And I know the Americans are very sold on it. The NICE, when we went through that, it wasn't actually, the evidence didn't stack up. There are a few other technologies emerging, which I'll show you, which have potential. But as things stand today, if you know somebody who has seizures, generalized seizures, you want to mitigate their risk, Amazon or Argos, 15 quid, monitor, put the battery in, plug it in. That's the thing. Quite a few places forget that. Then early age of onset. So if seizures start before the age of 16, of course, you're more likely to have an epileptic encephalopathy or a genetic syndrome, so you're more likely to lend yourself to SUDEP. Treatment resistance, defined as an absence of treatment remission for at least 5 years, is quite a significant thing. Again, a big chunk of people. Recently, we did a paper on that. Around 26% of all people with epilepsy in UK would qualify into that. Long duration of epilepsy, 15 years or more of it, again, a big risk factor, because something like 40% of that population who have 15 years or more of epilepsy will eventually die of SUDEP. That, I think, is quite worrying and stark. The other things which influence things is alcohol. Of course, because alcohol can have a knock-on effect, even if it's not a direct one, an indirect one, on your sort of circadian rhythms, sleep-wake patterns, etc. Non-adherence, compliance issues. Again, a brilliant study by Mike Kerr in Cardiff showed that hair levels, differences between those who were compliant and died of SUDEP and those who died of other causes of epilepsy. Excellent study which really nailed it, that compliance is an issue. Sleep deprivation and irregular sleep patterns, knock-on effect again into stability and seizure control. Prescribed drug changes. This could be an association but not a causation, because obviously more drug changes can happen if you're more complex, if you've got more seizures, etc. But yeah, worth recognizing it. So how are we doing with regard to managing complexity and risk factor? So when we looked at it, quite a busy slide, so I'll take you through it. We compared the risk factors of people who were only in primary care and those who were open to secondary care, and tried to find out whether there are differences and is the right population sitting with the right people. Now you need to make a decision on this, whether that's right or wrong. But if you think of medication adherence issues, those who had more medication adherence issues were in secondary care. Now for me, now you're not going to, we all know in secondary care, you're going to send a DNA note, you're not going to chase people up, are you, aggressively? At least we don't do it in Cornwall, where you need a car or a horse to do that. But I think this should ideally be a primary care situation where people should be engaged there. What we have is, again, the next bit, which is around depression and psychiatric disorder. A chunk of them, they're obviously more located with primary care. Maybe right, I don't know. Then correctly, those who had complex epilepsy were with secondary care. So that's a good thing. That's why it's a green. And then those who had intellectual disability, complexity again, in secondary care. again a good thing. But what's really worrying is those who were ending up with recurrent seizures, ending up in ED, there was a glass barrier to them getting into secondary care. Because this is another high-risk population which wasn't actually getting the services which is needed. So, in a nutshell, what we do know is that nearly 3 out of 4 people are not provided any seizure management advice after the first seizure. And this, what I need to tell you is that NICE since 2004, 2012 and now 2023 has repeatedly said that you have to talk about SUDEP after you suspect a first seizure. So there is no getting back on that. Then 3 out of 5 basically had no contact with health services after their first seizure. Then nearly 70% were non-adherent to medication, and this is improved a bit, 4% to 34% around information awareness. So one of the things which we did was bring in how do you communicate about SUDEP. So the way you do it, we created a simple checklist and to communicate and to hand it across to basically clinicians to discuss. And we did a before and after study basically to check on awareness improvement, whether it can work. And generally there was an overall reduction in the mean risk score. The people who were more risky and had more risk factors took on the advice a bit better and brought down their, improved their lifestyle. Of course, it's a 6-month thing. Whether it's sustained over years is a question. So the 25% of most risky people had a reduction. And what we obviously patted ourselves on the shoulder and said that our intervention of structured discussion results in behavior change, which will reduce the individual risk factors. And it's more effective in those who have higher number of risk factors, scare them better. So as you can see. So what it has done is that we have the seizure and safety checklist, which has developed over the last 10 years, and it is part of a range of array of tools and has been very successful, part of my 15 minutes of glory in one way, and is getting used as best practice. It's being taken up into Australia, New Zealand, and a few other countries. So here's a video in which SUDEP Action have developed around that. We have recently created one with reasonable adjustments for people with intellectual disability to help them. And I'll come to that as to why that's the case. So basically in 2015, we converted checklist, which was clinician, to a patient support tool, basically to hand it over self-management to patients called EPSMON. It's free to download, free to access, and we've got at present around 5,500 users who use it and update it every 3 months and been doing it so for the last 8 years. But it's failed, mainly because there are 600,000 people with epilepsy. This is a free app which is there, and you've got only 5,000 users. So, and the action, every single charity has supported it and promoted it, but we still struggle with it. And there is a reason for it, because we recently looked into analyzing some of the data from it, and what we found, we looked at maternal mortality in epilepsy, which is one of the big killers in generally for maternal mortality. And what we wanted to look at, because women stop their drugs at the time when they become pregnant, we wanted to check how aware are they of the counseling and working. So again, as I said, the papers are all available and free. It's one of the largest cohorts that we looked at, 2,158 women. And to cut a long story short, women, when they did it in the first assessment, weren't aware of SUDEP or pregnancy risks. But also, when they did it 3 months later, after the education module, many of them were still not aware of it. And that is a worry, that we are telling people, but they're not listening. So there's something wrong in the way we are telling it. And this is the main thing, is that there still remains a population out there who we think should know, we think we have told, but hasn't actually got across to. So we need to start thinking about different ways in which to make it person-centered and intersectional. Because why would an 18-year-old girl going to college be worried about pregnancy if you're giving her advice on that? She needs to know it when she wants to be pregnant. She wants to know about it when she wants to have a family. But can we deliver it at that moment? That's the challenge. So basically, yes, I think there is something where you can have something like EPSMON to play a role, but we need to do a bit more deep thinking on that. Coming back to SUDEP, so we do have new technologies emerging. So Nelly is a product which has come through, which is basically looking at seizures. It's machine learning and AI. So they capture movements at night and then juxtaposition it to already validated 7,000 seizures in their bank. And with each seizure which gets validated by the specialist, that goes into their bank and it gets used. So it starts giving you sensitivity scores. Very powerful tool, but still has some distance to go before we can reliably use it to help make judgments, clinical judgments. The other one is neurognostics, and it's again one of the tools which can predict seizure prediction. I'll allow my colleague to talk about it. We have just started the randomized control study, the prospective one on this.
Contained within the electrical activity of the brain. We want to bring this power into the homes of people with epilepsy to enable them to record their own brain data without repeatedly attending clinic.
So why is this important?
Neurognostics technology is not reliant on observing seizures. Instead, our AI algorithms reveal this information from seizure-free EEG. Excitingly, we have evidence that our patented BioEP seizure risk score can indicate whether a person with epilepsy is responding to their medication. This uses only short segments of EEG data that could easily be collected at home on a daily basis to personalize treatment.
So I've somehow ended up in this bed with all these geeky mathematicians, and we get along very well. After 10 minutes, I don't understand what they're saying. I don't think they understand what I'm saying. Makes perfect, this thing. Then Unique is one other one. It's long retainable EEGs. It will give you 6 months of data. It's like a credit card which goes in there, works on body heat, and then there's a 3-hour AI package which will synthesize all the evidence. All these technologies are great, but at the floor level, we still have that patient who is homeless, basically having seizures due to alcohol, attending ED, getting patched up. How do we take care of them? Because this is not just about a medical model. We hinge to that because we're comfortable, but there are issues about social need. It's unquantified. And that's the big challenge. Donald Rumsfeld basically said that there are known knowns, known unknowns, and unknown unknowns. I think there is an ocean of unknown unknowns. The sooner we start moving unknown unknowns to known unknowns, we'll be in a better place to deal with this thing. And that sort of comes back in my last minute. I'm going to quickly say that are current guidelines good enough? I don't think they are, because they talking about SUDEP at the first seizure. How is that helpful when SUDEP is more likely when you are treatment resistant 10, 15, 20 years down the line? And where is the research on the long-term effectiveness of a single discussion? And then what about SUDEP advice being dynamic and person-centered? And it's sort of which of these snowballs is going to crash. You can talk to each of those snowballs, but they're going to go at different paces, aren't they? That's where we came up with a new matrix, which is basically a minimum standard, do what you're doing, but also a desirable standard, which is very important, that you have to think about risk, change in risk, and engage with that. And finally, I think this is where I become grandiose, thinking as per gospel of Rohit, where if you are talking about management, generally to SUDEP or anything, you have to think about genetics, medication, big data, technology and apps, and think about precision medicine and socio-environmental change to deliver personalized, holistic care. So in a nutshell, this is the model that you want to work to, which is basically personalized, participatory, preventative, and productive, but also time-sensitive and reactive. So in summary, generalized seizures, whatever you know or didn't learn today or anything, generalized seizures, number one cause, the main cause for SUDEP. And there is growing evidence that we can do something. It's not unexpected. The event is unexpected, but we can prevent it. Think about cumulative risk, which happens. Focused discussion on modifiable risk, which includes seizure monitoring, nocturnal surveillance, and compliance. Very, very important. They are easily mitigatable factors. And standardized tools. It seems like a one-eyed man with cataract in the land of the blind, but these tools can help make a difference. And basically, what you have is repeated of this thing, feedback, always from families and carers, is that we want to know. They want to understand SUDEP. They want to be aware of it. And we learn a lot from families who lost. There's a lot of wisdom there. And a systemic approach to discussion of management and risk is helpful. And we need to recognize that epilepsy sits within a broad church of various social and health determinants, can't be seen in isolation, and evolve the continuum of care. So I'll end with this, because what you have, you might get the elephant on the ball, but it will keep slipping off. You have to be wary. For that particular patient who's at high risk of SUDEP, it's really important to keep an eye on the balance. Thank you. Sorry about the delay. It's the sound.
Another fascinating and important talk. I'm just keeping an eye on the time, but I think we'll probably have a chance for one quick question. At the back there.
Thank you. I love a good build-up of silence. Thank you, Professor. That was an excellent talk, and I think you hit it right on the head. Part of my job as a neuropsychiatrist is enacting behavioral change. And that's what I think this is all about, because we all put off, losing weight, stopping smoking, drinking less till tomorrow. But these patients sadly died tonight in their beds. So yes, an app helps, and yes, awareness helps. But I wonder, because I often think back to the patients who do get better, start taking their medicine, stop having seizures, start a relationship, get into work. What did I do? And I wondered if, for people in the audience, what do you think you can do to make a connection with somebody who thinks, I'll never die from this, it's not going to happen to me?
I think it's always challenging, isn't it? This And I do believe that each person's different and they come with their own socio-emotional baggage. But what I think our perspective as clinicians is very much about educational facilitators. So I think the knowledge which we have, which is here, however murky, however unclear, has to be synthesized and presented. And I think it's for the patients and their families then to come back with what they want to do. But also I do recognize I'm being a bit of a hypocrite here, mainly because a big challenge is a population which sits outside all this, who are homeless, significant mental health issues in rural, especially in socio-deprived areas, unlikely to take medication, tend to have alcohol and other issues, and reaching them in a way is almost significantly challenging and almost requires for those who are old enough and grey enough like me to remember the assertive outreach team. It's almost that we need that sort of a 20-year experienced nurse ready to go and knock on somebody's door and say, we need to do something for you. Get on with it. Take your medication and work from there. I'm showing my narcissistic tendencies here, but that's what it is. I don't know if I answered you in any sense.
Yes, you did. Thanks very much.